Welcome, everyone. I don't know if this is crackling too much. I'll try and keep it a certain distance and not move it. I think the movement's causing problems. So welcome, everyone. This is our 2022 Research Conference for LPFT. Absolutely thrilled to be able to do this on a face-to-face basis, and it's great to see everyone today. And it's great to see the stands and the poster presentations as well. So first shout out to Tracy and the team for organising this. It looks like a terrific event. I apologise for the crackling. Should I
just talk for a minute and I'll do the mic. Sorry, everybody.
Let me put this down. I'll try and shout, and I hope everyone can hear me. So thank you everyone for attending, and thank you for those who are virtually attending as well. We'll try and make this as interactive as possible. There'll be opportunities for question and answers, I'm sure, as we introduce the speakers and we have the speakers able to present, and we'd have questions there. So I've got a few notes today because there are quite a few things that we need to cover before we start with the day. So we've got the housekeeping wise, we've got fire exits this side and that side. You should be able to see them for those in the room. There are no fire alarm tests planned, so if there are any fire alarms, we will head to those areas and I think gather into the car park as the muster point. I hope everyone's familiar with the layout of this centre, but there are toilets on different levels. We plan to have lunch downstairs, almost in the room immediately downstairs from where we are. That's perfect, thank you. I've got a few more points to make. So comms will be taking pictures throughout the day, so photos of everyone. If you do have any difficulties or you don't want to be part of the photos, can you please let the comms team know as they do that. Please use Twitter as well. We've got a hashtag LPFT capital letters and research as a continuous word. So please do tweet as much as you can. Of course, at LPFT NHS is our, as a provider, as a trust, our hashtag as well, and our Twitter handle. As we do one of the talks on the siren study, I just ask if we don't take photos or don't do any videos at that point, because we're actually releasing it as a special release in terms of the study points, so we can't necessarily have that shared, but it'll be part of the talk for siren, so just something to be mindful of. I'm sure the presenters will remind you of that close to the time. Today and this morning particularly, we're really interested in theming this conference about increasing everyone's participation with research. It's such an important part of what we do as clinicians, as practitioners, as people providing healthcare services for our patients. And we need to get as many people involved as possible from different backgrounds. So it's an absolute pleasure that we're going to be starting off the day talking about how we can develop our workforce to improve what we do in terms of research. The next part of the day will really be focusing on delivery, and I'm thrilled that we've got breakout rooms where we can actually talk about different studies that we're currently participating in. And later on in the day, so the afternoon part, we're looking at development and evaluation. We'll have the opportunity, of course, to then announce our poster and stand prizes. So for everyone as you're looking at your table, you'll notice one of the stands has got a QR code, and that QR code is different on each side. So it gives you the opportunity to vote on the stands of your favourite stand, so we can award a prize at the end of the day, and also the posters. And the posters are available through that QR code, but also situated just downstairs. I think some of you would have seen that. So just to mention that as well. So the other thing I just wanted to mention, as I've got the opportunity to do so is the research team from October are planning to set up the Research Roundup, which is going to be emailed to everyone in the organisation, and it's going to be an opportunity to really increase the visibility of research within our trust. So try and ensure that everyone's familiar with what's going on in the research team, who's in the research team, and improve everyone's opportunity to get involved as well. So that'll be a monthly update, so keep an eye on that. I think it's through the weekly word. Brilliant, so you find that on the weekly word updates. Just to mention, you've most likely seen the agenda, which includes different options for breakout rooms. Room 1 is at the Lincoln suite, so it's this suite here. Room 2 is at the Hartsome suite, which is downstairs, and room 3, or option 3, is the Moreland suite, which again is downstairs as well. So I think that's it for my intros. So without further ado, I'm going to hand over to Dr. Joanne Cooper, who's planning to talk to us about the strategy on research from a nursing perspective. So over to you, Jo.
Good morning. Thank you very much for inviting me here, and hello to all those that may also be joining online. So my name is Jo Cooper. I have 2 roles currently. So I'm here today in my role as Head of Nursing Research Transformation at NHSC, and that's within Dame Ruth May's team as part of the national team. I also work 2 days a week as Assistant Director of Nursing at Nottingham University Hospitals, but did have a couple of years working at United Lincolnshire Hospitals, well, about 12 years ago, leading on research capacity. So Lincoln is very much a home for me. That was my first venture corporately into developing for nurses, midwives and AHPs opportunities to embrace research as part of their career. And that's really part and parcel of what we're all trying to do, is to improve patient care and outcomes through research. And with that, have the opportunity for staff to have that as part of the role. So my job today is really to outline to you the CNO strategic plan for research, and it will be a bit of a whistle-stop tour, but please feel free to email me and I'll ensure that you have my details. And can I first of all, though, say thank you to Sandra Townsend for getting me here today properly and for all her support in getting here. So thank you, Sandra. So the title, as you see here, is Making Research Matter. And it was a plan that was launched in November 2021, right at the height of the pandemic. What I would like to do today is just to give you a bit of a flavour of the national context, very briefly. But it's important to do that because this is really part and parcel of the national direction and a multi-professional direction for research. Then to outline some of the key elements of the strategic plan. It is available online. I'm sure you all sleep with it in your pillow for any nurse here in the room, but I'll give you a bit of a refresher. And then I just want to give you a bit of an update on the progress, some of the work that we're doing. And I'm sure a lot of that will be of interest to you, but my plea is please support this, please be involved. Even if it's just commenting when you can, just following. But this is really where it will happen, at trust level, working together, rather than a plan sitting on a page or a website. So please, we'll need to achieve this together. So here you will see the future of UK clinical research delivery, commonly known as the National Vision. And I've just reintroduced this to you. This was launched March 2021, and it's important because we've called our plan a strategic plan, not a strategy, intentionally so that it sits within the national strategy for research, working closely with all partners, all professional groups. And if you take some time just to look at this, also considering what we're doing under the Reset programme as part of our COVID recovery that you will all be familiar with, I'm sure. You'll see some of those elements here that are very common throughout the strategic plan for research, including digital, including a focus on workforce, including the real kind of cultural change that is required and the systems that are needed. So just to ensure you, this is sitting directly within the national team, and we're working very closely together on that to achieve significant change. So it has these 5 overarching core themes in the middle, and then underpinned by the 7 actions, and represents a partnership approach. So Making Research Matter is the CNO strategic plan for research, as you'll see, launched in November 2021. And we were really delighted that Ruth was able to kind of reiterate her support for that. There has been a lot of work around research, both for nursing, for midwifery and allied health professions for some time, but this is really the first line in the sand for the profession, I would say, in terms of what that might achieve, and has come at no better time, where we've seen the power of research through our response in saving lives through the pandemic, and of course for other long-term conditions. So really it's around a collective approach, embedding research in practice and decision making, and not only in health, but in health and care. And if you take some time to look at the wording within the strategic plan, you'll see that's very much of intention. And we're working closely with Professor Deb Sturdy, who is the Chief Nurse for Adult Social Care. Well, if I was to ask you some of the changes, we don't have time today, but I hope that you would be familiar with some of the things here in relation to, so what are the changes that we would want to see from a strategic plan for the nursing profession? Bearing in mind, this will also be in line with the changes that allied health professionals, healthcare scientists, midwives, pharmacists would also want to see in relation to that. And so it's about it becoming business as usual in health and care settings, that we're able to prioritise and focus on those areas that our patients, our partners, our families really need, and what our most pressing public healthcare needs might be. With that, thinking where the investment and support for nurses not only to lead, but to participate and to deliver research in the NHS and social care. Acknowledging the fantastic contribution that those that support the delivery of research play in enabling a research culture, and that is often the hotbed and talent bed for those that would aspire to be principal investigators or to be leading programmes of research for the future. But of course, that also starts very much at the outset of a career. Some professions have it a little bit more established, although we realise it's not easy for medics either in relation to a clinical academic career. But how do we make that a reality for those in undergraduate training? And a real partnership with our HEI colleagues is pivotal in that, so that we have greater opportunities for nurses at all levels. So yes, those in consultant level practice, but those at ward level, those in GP practices, those across the health and care system would have an opportunity to engage in research, to engage in evidence-based practice, and where they wish to lead pieces of research for the future. Ensuring that as a profession, we're around the decision-making table, whether that's in relation to funding, but also in relation to the types of research that are important to patient and families' outcomes, so that we're able to show the benefits from that, and then also maximising the massive investment and innovations in relation to data science, AI and technology. And so you'll see some of these themes coming through part of the plan. So there's some of the changes. I'm sure you've got many more, and it would be great to hear, but please let me know. Do you think we're missing something? Is there something else that we need to know about, particularly with your expertise and with your area, and particularly around rural health, that is important to understand? So I'm just going to briefly outline now the 5 key areas of strategic focus. So the plan is a starting point, and we've given these kind of areas of direction, and I won't reiterate them in detail. You can read them here, but you'll see that these reflect some of the changes that we want to see. And what I'd just like to do is give you a flavour of some of the ambition around that. The plan itself gives more of the detail, but then to focus on, so what are we doing and how have we been doing since its launch in November? The first one then is aligning nurse-led research with public need. I was to ask you and your teams and your chief nurse, what are the most pressing needs for research that nurses need to be involved in? What would it be? Do we know? And I'm sure that's a real potential as part of this system developments, but you will know that more than many, what those real issues are and what are the methods and processes we need. So this is something that we're really committed to, so that the portfolios of relevant funders reflect those needs as well, and that we can show the outcomes for public and for the workforce. So in terms of the approach to challenges, understanding what they are and influencing the policy direction around that, this is where the plan is starting to have connections and influence. But I would call us all, and myself included, to be more sighted of policy and how research is embedded in that and how we can influence policy, whether it's locally, regionally or nationally, on the things that are really pertinent to your areas of practice. And we're offering policy masterclasses to join online should you want to be involved and become a member of that group. It's really important. Some of us have never had the opportunity to engage very much in that before, but also working closely with funders such as the NIHR and some of the charities on what opportunities there might be. And then thinking around demand signalling and prioritisation. Demand signalling is a process used particularly within NHSC and the Department of Health around policy questions. And I think it was yesterday that the mental health demand signalling was launched. So I encourage you to have a look at that, because this is an area that we're going to focus on as a priority in nursing. Really well cited for yourselves, and also we need your expertise. What might that mean for nurse-led research or for nurses in research? We're also looking to work with partners in children and young people, and also a piece around long COVID. And of course, couldn't really go without saying something around the community nurses and the prioritisation work they've already done. So please have a look. That's a James Linderlines approach, top 10 priorities for community nursing. So the second area, having thought about what are the priorities, where do we need to be and how do we influence the policy, what is it around releasing the potential that nurses have? Absolutely convinced that the appetite, the potential is there, but it's about how we give proper structure for that, but also how we work with our leaders, our system leaders, our executive nurse leads, and also our clinical matrons and the decision makers around how careers and workforce is planned. So you'll see here that the ambition is to create that climate where it's more able to function, considering particularly things around careers. So a lot of these overlap, but in essence, it's about ensuring that our leadership has that shared purpose and that we have that responsibility. So how do we ensure and work with partners such as the Council of Deans for Health, Health Education England, to look at the scope and opportunity for nurses to become more research aware right from the outset of their career, but also to look at how that embeds across enhanced to consultant level practice and beyond. Also considering what does it look in terms of fair and diverse ways. We know it can be challenging in acute NHS trusts to have opportunities to engage with research and for leaders to enable that. What does that mean if you're working in a GP practice or a social enterprise and all of those other things? So we're ensuring that our reach and the voice of the profession is as inclusive and as diverse as possible, not only in terms of setting, but the fields of practice, such as mental health, learning disabilities, and so on. We've been working closely, as I said, with funders around how that might influence and opportunities, which will help when we've done some more of the prioritisation work, but also the profile and visibility of our profession. I'd encourage any of you here to look at the NIHR Nursing and Midwifery Incubator site. That is an opportunity to put a pin on yourself if you are leading and involved in research, so that we can start to bring the community, but also our HEI colleagues. How do we know where our professors are? It wants to reboot. I'll say remind me later. So there's some of the work we're doing around leadership and releasing the potential of nurses. The third area then is in relation to building the best research system. So in line with the national vision, we want England to be the best place for nurses to lead, deliver cutting edge research with that coordinated infrastructure, and both in terms of the research activity, but bringing alive the timely adoption of findings. what we know there are key quality and safety priorities for our organisations. Often the research we have may not always align so closely to the needs of our profession and what are important on a day-to-day basis. So how do we bring alive what great activity is already happening? But I also want to acknowledge that whilst things are challenging, of course, to develop a career, for example, in research, we are very fortunate in England compared to some of the other nations around having the NIHR infrastructure. The Research Design Service that I know is here today is phenomenal in supporting this. But also to assure you, as summarised on the slide here, that we are working very much hand in glove with Professor Ruth Endicott and her team at the NIHR and with Professor James Sandel in relation to the common purposes here that you'll understand, but also with our allied health professional colleagues, so that any benefits any of us are doing in this space can help all of the professions because we have common challenges. So understanding the benefits, that positive culture, developing sustainable and supported workforce with sufficient capacity and capability as a common purpose, and then importantly, the dissemination of research findings. So this is work that we work very closely together on. And there has recently been a nursing midwifery summit at the NIHR, and I've seen there's a post advertised to support one for allied health professions to think about how do we, knowing some of the challenges, create some meaningful solutions to those. And then in terms of developing those future nurse leaders of research, we are committed to offering rewarding opportunities for that sustainable career growth, both in the number and diversity of nurse leaders of research. At present, it is challenging to locate our professors. So that's work we're doing in terms of a practical level, but also bringing the great work that's happening on a day-to-day level and how we might showcase that. So we are working, for example, to raise awareness. On the 6th of October, we have our third national webinar, which is in relation to palliative and end-of-life care. Our previous one was on mental health nursing. So if you have ideas and recommendations for future webinars where we can showcase research in that area, please let me know. It'd be great to work with you on that. Also championing careers, working with the NIHR incubator and partners on bringing alive what a clinical academic actually means, where those creative solutions have been made and what impact is it having, both of course on the individual, but on the patient outcomes that they are working on and their research. We've been very much working in partnership with Health Education England and other partners on career structures. This seems to be one of the big challenges, I think, for a lot of us. So, you know, you can get the funding awards, you can do the training, but what's your role going to look like? And so to think about how we might facilitate that and bring together some of the practical solutions and to dispel, I think, some of the myths around what can and can't be achieved in relation to joint appointments. But it's fantastic that we have our university partners and you have them here today, because that's where the magic will really happen in making and enabling that. And then also a piece of work that will be going forward in the future, looking at, for example, the advanced clinical practitioner framework. We know that the research pillar is not as strong as perhaps the clinical. What does it look like if you're majoring in research at advanced level? And that is a piece of work that will be going forward in the next year. So it'd be great to have your voice in relation to that. And then finally, in relation to digitally enabled research. And I won't go into great detail on this. Helen Bolston and Dr. Natasha Phillips are the leaders in relation to digital research, and they are leading this with us as partners. But basically, it's really around maximising the opportunities for those that are leading research in relation to digital. But all the innovation that's happening in practice, from electronic patient records to data and health data, how do we make that both understood and available, and really maximise the roles of the chief nursing information officers that are out there? So in just summary, here's some of the strategic actions. It's about building that digitally enabled environment, developing research leadership in digital technologies and data science, again identifying the priorities and enabling research, and developing that robust data architecture, all of which Natasha and the team are leading. So coming towards the end the presentation, just a couple more slides. This is a summary for you of some of the selected activity that we have been doing to try and bring some of this work alive, and not all of it is here, but just to give you a flavour. So we are currently working with the Florence Nightingale Foundation to develop and understand what a programme to enable research would look like for our executive nurse leaders at ICB and organisational level. We also have a breakout session at the CNO Summit for research, so really opportunity for us there to engage with our chief nurses on what would it good look like from their perspective. We've commissioned and just received a piece of work in relation to race and health, mapping against those 5 key areas of action. We've also been working with Nicola Verstralen, who's an NIHR 70 fellow, on a Matrons research toolkit. If you haven't been involved, please do. We're just going out to second tender shortly for that piece of work so that we can really enhance and help our leaders enable research and understand what that might mean from their perspective. I've already mentioned the demand signalling in relation to priority setting, where mental health is our first stop-off point. We have a transformational leaders group. So essentially it's those working in organisations who are responsible for enabling a culture of research for nurses and midwives. So anybody here, or anybody would like to join that, it's very much a support and sharing group. We'll be going out very shortly for the second tender of our SORT tool, which is an organisational self-assessment readiness tool against the plan, led by Professor Joe Cook initially, the first one who did the Victor tool. So how do we know where we are now as a baseline, and how using a maturity matrix might organisations know where they're developing? There are communities of practice in relation to community and primary care nursing, building on some of the priority setting exercise, but a great community to be involved in if that's of interest to you or colleagues. And we also have a shared decision-making council for research nationally, should anybody be interested in joining that too. So in summary, this is where we're at. I know it's a little bit small, perhaps you can see it on your screens. We're at implementation stage now. We will be publishing our implementation plan, hopefully in the autumn. But this is an ongoing piece of work that's been going well before the plan and will continue for the future. So please support us and join us in this journey. But just to say thank you for the opportunity, it's brilliant, and it'd be great to hear any recommendations you have or any questions, and thank you for having me.
Question.
I'm happy. I've got time.
Yeah, I'll just open up for some questions. We've got a couple of minutes, so has anyone got a question?
Thank you.
It's fun.
I can hear you. I can hear you. Yeah, so that, just in case I didn't know, it's in relation to the really highly qualified clinical research practitioners. This really sits with Professor Ruth Endicott and her team more primarily, but I think they have a pivotal role both in relation to supporting research in what their career options might be for the future, but particularly also bringing knowledge dissemination and mobilisation, because I think that is something I haven't gone into today, but it's something we really need to get a lot better at. It's not a role I totally fully understand, so I wouldn't want to make a definite comment, but of course, anybody who's a champion and ambassador of research, it's great that these roles are here, and we want to maximise them as much as possible. So please let me know what you think your recommendations will be. It'd be great to take that back to Ruth.
I'm going to take Chair's prerogative and actually ask you a question, so you can hang on to that. I'm really interested in take-home messages for the trust, and I believe in top 3 things. So what are the top 3 things we as an organisation? I've got the CEO sat down there making notes, I can see, very industriously. What should we take away from what you've just said as an organisation?
I suppose top 1 would be please look at the plan in relation to the needs of your organisation and the potential in your organisation, and formulate that into some ambitions if you don't have them already. I don't know whether you have strategic ambitions for nurses, midwives, and all of those, and make that clear in relation to your organisation, because one of the success factors has been really around that commitment and direction around which people can galvanise. Secondly, you have great leadership here. I think it's about strengthening any opportunity to look at someone whose role is particularly around clinical academic career development and working with partners, whether that's investment in joint appointments, supporting clinical professors and people working between organisations, then that would be that. Thirdly, I think it's around working with us nationally to realise what impact you would need to see should you invest in this. What would it look like from your perspective, and what do benefits from research really look like, and make that available to all your clinicians, to your matrons, your clinical leaders, because some of the challenges that we face is really articulating where it's transforming change. That's off the top of my head, but I'm happy to kind of go into detail about that more later. Thank you for the question.
Thanks very much. Thank you. We'll just give a round of applause. Right, I think we're spot on in terms of time. So thank you very much for those interactive comments. I'm going to now hand over to Professor Kate Grafton, who's joining us to talk about the AHP Research and Innovation Strategy. So without further ado, over to you, Kate. Got that? Yeah, thank you.
Sort out my workstation. I'm going to see if I can be able to wedge this. See what happens. Do you think it'll work on the side?
I can hear when you did that.
It might fall over though. So, sorry. Are you doing that?
So you do.
I'll get the next slide. Okay, so thank you very much for inviting me to come talk to you. And again, thank you to Sandra for her patience in certainly organising me. And I don't know about others, but so my name's Kate Grafton. I'm a Professor of Allied Health Professions Education. And a lot of the work I did to achieve that professorship was undoubtedly around allied health professions education, was really a lot around postgraduate workforce transformation and quite a research capacity development, engaging with the Council of Allied Health Professions Research Network, which I'll talk about a little bit about here. I'm also Vice Chair of CAPA. CAPA is an organisation that was formally launched in its current structure in 2014, and it brought together allied health professions as 14, possibly 15, depending on how you slice and dice the professional boundaries of it. There was lots of activity going on, lots of different networks, and it brought together all those AHP networks. So AHP make a third of the NHS, well, the clinical workforce. So to bring people together with one voice, because I think as you'll discover, some of what I'm going to say overlaps massively with what Joanna has just said. So it's about pulling things together there. So the mission really there is around getting collaboration around those initiatives, talking with one voice, creating one coherence of networks out there across its UK wide, so not just England, but so pulling people together, so share expertise, share experience, whereas activity before had been very much professional body driven, and there are some who physio, speech and language therapy had been very successful and there was a lot of impetus, but a lot of other smaller professions out there with much less engagement, or had in the past much less engagement around research. So the ODPs, the paramedics, they're starting to do quite well now, who really needed that hand up and pulling people together, sharing and pooling resource thinking, because research is a multi-professional business. So CAPA is very much a network. It is largely unfunded. There's a little bit of funding that comes through the professional bodies. And as a result of this work we've been doing with Health Education England, we have received very small amounts of funding, but it happens primarily what I call in the voluntary sector alongside people's day jobs, because they're passionate about it and they care. So, and that's very much how I've engaged with this. It's always been alongside my day job. My day job, what pays my salary, is I'm head of the School of Health and Social Care here at the university. Now that school encompasses allied health professions, nurses and midwives and social work. So we're in a great position to really pull together that interconnectedness to help move this strategy forward. So, but this isn't about me, this is about the strategy. So if I move on to the next slide. So the strategy has been developed really over a couple of years. It has been driven, and some of the development work was funded by Health Education England, driven by Bev Harden, who drops very small pockets of money in key strategic places, and everybody works very hard to make sure they make the best of it. So the approach was the work, they collaborated with CAPA. CAPA is essentially a network. It has a professoriate that has been a little bit dormant over the as we've gone into, well, as COVID hit, and we're just reinvigorating, reshaping that. There's a strategy committee that comprises of a representation of each of the professional bodies, pretty much on this slide. There's representation from HEI, representation from senior professors, clinical researchers, and managers as well. We have management. Some of the managers are not researchers, but we recognise that is a key implementation. So there's a strategy committee that really captures all the perspectives, but actually crucial and a USP really of CAPA is its hub network. So there are small groups of hub networks across the country. They receive sort of minuscule amounts of funding to deliver local activity, to engage. It's very, very ground up. This isn't, to use the terminology in a minute, drop down economics. This is ground up innovation and driving the agendas forward. So the strategy has been developed really in partnership with each of those professional bodies. They've very much signed up to them. Health Education England, Council of Deans and CAPA. And I was involved as part of the CAPA role. It was launched a year ago to much fanfare. There was a breakfast broadcast launch, which Suzanne Rastrick has, the head AHP said, oh, this will never turn up. No, nobody will ever sign up to this. It was oversubscribed, and I think about 80% of those who subscribed were online. I couldn't get online. I was too late, but I saw the recording. So a huge amount of activity, events, and really starting the momentum, getting it out for people to engage. And that's so there's a year plan. There will be continuing the conversation campaign that comes through into January 2023, and there's an event to organise. But it's about the context is now we've been dripping along. We've been doing lots of bits of activity. The AHPs, people start to think, oh, AHPs can research. It's the strategy is about, it's a time for a step change. It's a time to pull together. There's lots and lots of threads of enthusiasm to pull those together to get a real impetus to change the agenda, to step up the agenda. So research innovation, how's it been defined? Here, really, it is a very inclusive definition that we're looking at. It's really all spectrums, going from quality improvement right through and excellence of practice, right through to what I call your randomised controlled trials, the NIHR structured research infrastructure. It's about evaluating practice. It's about impact. We want it to go across all sectors, all job roles, all career stages, practitioners, educators, research managers, policy leads. All are absolutely crucial to ensure we achieve this step change. But ultimately, the key focus, well, it's 14 professions coming together, is about what is the impact on patient care, professional practice. Ultimately, everything must lead through to that agenda. The strategy is also structured around four key domains. So capacity. So it's about capacity and the ability of that AHP workforce to engage in research, to engage in service evaluation. It's a continuum, and people will need to start potentially with service evaluation and then move through to larger research projects as they develop, really as they develop their capability and their confidence. So capability is about for individuals. As a sort of, if you like, a procurer, overseer of lots of pre-qualifying education programs, our education programs have a lot of service improvement in them. They don't have a lot of core research skills. And that's because we've got limited time, we've got professional bodies, and as we've talked to partners, that is what they want from the entry-level graduate. So there's investment needed to support those staff to develop their skills, to bring in more research skills, to think actually research is for them. It's not something that happens over there. It's about context, so equitable access. So can all AHPs, do they all have opportunities to engage? So physios, speech and language therapists, they've got lots of role models. They've seen somebody that's a physio, they're doing that, I want to do that. ODPs, how many ODPs? Well, we're on a mental health trust, so ODPs isn't a good example. But how many of those smaller professions, so I'm sort of having to think around, dietitians, they all sit in different trusts. Somebody give me an AHP profession that's employed smaller ones here. We've got speech and language, they're really, given the size of their profession, they are really well established in research. And I think some of that was because they were a degree profession a lot longer and well before any of the other AHPs. So physios, OTs and speech and language therapists, I think primarily AHPs that you've got in this trust are really well established, but there are lots of smaller professions who have a lot to give to. So it's about equitable access as an AHP forum, how we can use those well established professions to help the newer professions start to engage and move through. And I think paramedics is a key one of those we're starting to see as a success story, but also EDI from different people's perspective, job roles. Research is everybody's business. Yes, there's clinical academics, but we also want all clinicians to be users, consumers of research. And I guess in the broader context, if you look at, when you looked at the slide of who's on the capital strategy group, the core group delivering it, we are all white. We need much more inclusion to represent the professions, and the dimensions and sort of populations within the professions has changed massively over the years. So we need all voices to be heard. And then context. Research is everybody's business. It's the leadership, it's the management, and that's where we need, I think, presentations through groups such as this today are absolutely crucial. It needs to be better in organisational infrastructure. So, how am I doing for time? Okay. So there are three key strategic vision statements published on the strategy. So transformation of the AHP professional identities, cultures and roles. So this is about a shift in awareness of the skills and values and expertise that sits in those professional groups, that we look to sort of really develop those skills across the AHP workforce community and across all stages in a profession, an individual's life cycles. So as educationalists, we really need to ensure we have research informed teaching and that the students know what they are learning is embedded by research, and we make the connections and link back to the core. We need to ensure that we have dedicated time and opportunities for our academic staff to not only deliver and teach the students, but to engage in research activities. We need to do much more around research and innovation placements and internships. A lot of our placements, they are clinical placements. And this is where we trip over a little bit with some of the professional bodies around how they count hours. And students want clinical placements, but actually we need to leverage and put more research and innovation placements in. And I put that alongside leadership and education placements, which we don't do so much of. And we potentially need to reach out into networks. We can do some within universities, but we need to reach out to research or sort of research groups out in the healthcare system. Definitely we need research. It needs to be embedded into job descriptions and routine practice across all career stages in the AHP workforce. And if I was asked what's one of the top 3 priorities for this trust, actually, is that there embedded? And if it is there embedded in people's job descriptions, have people actually got time and capability to engage and to fulfill that? So advanced clinical practitioners, ACPs, 4 pillars, research, but you go in, they have 10 clinics a day, 10 sessions a week of clinics. When's the time for them to engage in the leadership, education and research? It gets squeezed out against the clinical priorities, and it's a juggling act. It's creating the space for the longer game, for the longer window, and ensuring really that the roles and career routes for those that think, actually, I want to make this a much bigger part of my practice, that they're clearly signposted and that staff are supported. There are lots of opportunities out there, but often it's difficult for people to engage because they've got the funding, they can't get the backfill. So the number of staff who I've met who, actually, I just work 0.8 because I know I can get bits of funding. I can then increase my hours and decrease my hours according to that. But that's the individual taking that risk. They should be able to work full-time, employed full-time, and the organisation manages that increase and down and step up and step down according to what potential opportunities, funded opportunities there are for them. If we look at delivery of excellence and evidence around AHP practice, so this really aligns with, it's talking about directly aligning with and contributing to the priority agendas. So Joanna mentioned about these. What are the sort of national health, the care, wellbeing strategies? We've got to connect the activity that we do with those national agendas. Connecting with national agendas, it's easier to leverage time, and there is often funding to support. So we've got to be a little bit savvy there. But in addition to that alignment, we've got to achieve visibility. So when people are developing those national agendas, that they are talking, from my perspective, AHPs have got a voice in there. Have nurses and midwives also got a voice in there? So a lot of what Joanne and I say is very, very similar, and there is a lot of connection going on at national level. But that visibility and that ability to influence. So influencing the agendas, influencing the funding stream, making sure when opportunities are put out there that the idea may have come from a medic or it may have come from a nurse, that the opportunity isn't just structured in such a way that it excludes AHP. And that sometimes is just about inclusive language. It's just making sure that in the job criteria must be a nurse. Well, why must they be a nurse? Why couldn't an AHP do that? So there's that visibility, and as well alongside that, so there's ensure we've got legacy, we've got leadership. So there's a momentum, there's an impetus now. There'll be a lot of activity that rolls on over the next 3-5 years. We've got to ensure that this becomes better. It becomes a part of, I guess, business as usual. And we need everybody to commit, whether that's LPFT as a trust, HEI's committing, so that as an HEI, we're not just looking at what do we need to do for the REF agenda, that we are able, my job is able to try and influence the University of Lincoln to invest in the NMAP's workforce research agenda, the AHP. It's a longer, slower burn in terms of some of the returns that the university is looking on, but we need to have the long game in as well as the short game, because there is huge expertise, huge potential within that HP workforce capacity as a third of the workforce, and then you bring nurses and midwives in as part of that. The NHS cannot afford to ignore that as research leaders, people that are going to drive and become PIs in studies. And then the final one I think I've pretty much covered is really around those strategic agendas, that everything is embedded within that. So ultimately, as a summary to pull this together, the strategy is around impact, very much around impact on patients. Going to move quite quickly through the last few slides. Challenges. There are lots of challenges. These are things we should do. Some of it it looks easy, but actually some of it isn't. It's quite hard to do, and we need to work through how we overcome those challenges together. There's a lot of work going on around the visibility, reputation. There's a lot going on around social media, tweet chats. We have there's an NIHR HP Research Champions Network. There's a lot of mentorship role models. So a lot of activity underpinning all of these areas. I'm starting to run towards the end of my time, so I'm just going to go a little bit more quickly. Strategic response I've talked about. This is just a slide that captures some of the evidence, what's been written around those clinical academic careers. So clinical academic careers are important, but also research in clinical careers is very important. So joint posts. Strategic response, there's been a lot happening, and that this captures some of the key documents that works around Council of Deans for Health have been doing around how we put research education into pre-registration programs and what we need to be able to do to enable and facilitate that. Linking in, as I mentioned, with funding streams, other strategic, these again, just a few examples of where we're starting to see wins and gains, and it's important that we promote, we tweet around those gains, we share those successes, we capture the case studies. There's a lot of work going on connecting in with the National Institute at the NIHR around the showcase event. And then also on, I've got the date here, 25th of January, 10:30 to 2:30, there is an AHP Research and Innovation Strategy 1-year anniversary celebration event. That will be online. First come, first serve. We'll be able to engage with it and to go online and be able to engage, asking questions, etc. For those that aren't able to do that, there will be an unlimited number of places where they can watch the whole event live streamed on YouTube, but they have to sign up. So CAPA, so come back to CAPA. Really, I put this slide up to context. The person who's been driving this work is Hazel Rodham. So she is a key person. If you want to go straight to what's happening nationally, Hazel, I'm linked in with the CAPA element of work, so that's my email address. And for those of you who haven't seen the strategy, there's a QR code. Get your phone out, scan it now, go and have a read, and it takes you to a web page where there's captures various case studies and other elements of activity. And the other website to go to is the CAPA website. So thank you very much for a whistle-stop tour of the HP research strategy.
Okay. Thank you so very much, Kate. So it's really handy that we've got contact details, I hope, that will be shared for both speakers. So I'm sure there's a lot of questions that we may have and connections to develop there. Now, the next speaker, I think, is going to be connected virtually. Jackie, we set up, so just move straight into the next one. I mean, hopefully we're running a few minutes over.
Change of plan for the next speaker and been able to attend, so we're going to have to do this through Teams.
Jackie, I am ready actually.
Just a second.
Yeah.
Bear with me.
So I'll just introduce the speaker whilst we're doing the item. It's great to introduce Dr. Sudhir Lankappa, who's going to be talking about a GMC statement on clinical research for medics. So it's great to have you along, Sudhir.
Just 1 second.
Just going to connect you with the audience.
Yeah.
Thank you.
Talk amongst yourselves 1 second.
Right. Can you hear me and see my slides?
1 second.
Not just
Ah.
yet.
No, I'm doing the wrong one. Just a minute. Yeah. That's that one there.
That one.
Okay.
It's not coming up on the
Hmm.
main screen.
Very odd.
Sorry, everybody. Technical.
The other options, if we email receive the slides separately, we can just manually flick through them. That's
Wait a minute. Just
I
I think, yeah. Why it's not sharing that.
Yeah, I think it should.
No. We're okay online, but we just can't get you on the big screen in the room. Just 1 second.
Try again.
That's online though. It's just what's in the room.
Close the PowerPoint down. Let's close it down.
No,
That's better. That's better. So
No,
if you
that's
can
not
just-
my slide.
Yeah, that's better.
Okay, can you share your
It should-
slides?
If
Yeah.
you share your screen, it should work.
Okay, let me just. Yeah, can you see me now?
Cool.
My
Is it
slides?
moving here.
Yeah. Okay, can you see my slides? Yeah.
Yes, yeah.
Okay, right. Thank you very much. Yes. Right. Good morning, everyone. I'm sorry for the bit of technical delay there. Firstly, I would like to thank Tracy and Sandra. They've been extremely helpful to me. We had a bit of problem this morning as well. And thank you for the trust to inviting me for this conference and giving opportunity for me to present a topic which is of most relevant at present in the current context. Normalizing research and promoting research for all doctors. This is the GMC position statement. As you heard from previous speakers about allied health professionals, I think similar things are mirrored even for the doctors. So the GMC has taken this, and this is work in progress. It's just not necessarily GMC is the primary organization, but it's multi-agency, various organizations are involved in this, and hopefully we will have some ground level changes in the near future. So we all acknowledge, and that's what GMC has acknowledged, that there's plenty of benefits if a clinician get involved in research. So there's an huge advantage for individual patients. They may be able to get new treatments or new investigations. There's a change for overall patient care. There's benefit for healthcare teams and the organizations, local trust, and also GP practices. And for individual clinicians who take part in research, definitely there's a huge advantage for them and a benefit in terms of career progression. So what's the aim of this position statement, or what does GMC want us to do with this policy? So the aim is to enable a culture in the workplace to encourage doctors to be research aware and research active clinicians. So that's the aim of this. And how does this look? So what is the practical way of looking at this objective? So first is, an individual helping patient to understand research and clinical trials. A junior doctor or a senior consultant could do that. Then working in research teams to recruit patients. So often we know that, when you are having a full-time clinical job, it's very hard to do these kind of things. But if you try to help them to recruit a patient, that's good. If going further, you could consult patient for research, working in a local research teams or projects. And also there are scope for coming up with novel ideas and developing your own research. So that's what GMC wants us to do. And pursuing academic careers, if you're still very keen and interested, we could actually go further and start to look at some of the research fellowship programs that we have, and providing leadership to the teams and to the organization itself. As an individual, again, you could disseminate research findings to patients, explaining things to patients, and incorporating research evidence into day-to-day clinical practice. I mean, that's the most crucial part of it. So you can see it's quite wide range, just supporting a research team up to actually leading a team or disseminating and working on bigger projects. So we've got plenty of opportunities during our clinical work where we could enhance our skills with research. And this is the organization they're working together. So GMC, you could see that NHS Education Scotland, Department of Health and Social Care, CQC, UK Foundation Programme, BMA, Royal College. So there are various organizations which are now focusing on this theme and working together so that over a long term or, they would actually find some benefit and help the clinicians. Obviously, there are plenty of challenges. As the previous speaker was telling, if they have a busy clinic, where's the time for research? Yes, I think that's one of the barriers. So they all acknowledge, all this organization acknowledge that we do struggle with time. We always prioritize clinical work or managing busy caseload. So they are looking at this, actually, there should be a protected time for research activity. And empowering all healthcare staff to recognize need to participate in research as part of their job. So that's what is important. So your immediate line manager, if you are a consultant, then your clinical director should put that in your job plan. If you're a trainee, you as a clinical supervisor or educational supervisor comes up with a job plan so that you have some time and opportunity to work in research projects. In addition to the routine problems that we have, there's also a wider acknowledgement around various organizations that there are unmet needs for people with ethnic minority or people who are disadvantaged, maybe because of their work, maybe because of their gender and socioeconomic status. So there are various steps to address this problem. And they're now saying that there should be a specific intervention introduced locally within the trust if they acknowledge or if they identify this kind of the discrepancy between people who are advantaged and disadvantaged. Whether that could be for a trainee in a specific job or it could be for patients as well. So Department of Health acknowledged all these things, and they've got these key themes that they are looking at it, which was published in policy paper, The Future of UK Clinical Research Delivery. So they would like to streamline and be efficient and innovative in research, clinical research embedded within the NHS. I think that's the culture that they want to bring in the future. And it has to be patient-centered research. And research enabled with a lot of data and digital tool and sustainable and supported research workforce. Okay. Now, GMC has got various outcomes, we would say, for doctors, depending on the grade and the level of training. So they would like trainees to have wide range of exposure throughout their career. So let's start with the medical students. So there are clear set objectives and standards and the expectation for a undergraduate, then a clear standard set for core trainee and a special trainee, and also for the senior clinicians like consultants. So we could look at the good medical practice there. The first domain, that is the domain 1 with knowledge, skills, and performance, they clearly want that a doctor must be competent in all aspects of work, including management, research, and teaching. So this is the core attributes that or competency that a clinician should achieve. There's also some kind of expectation from GMC that there should be some outcome, and this outcome should be met during the training. So if a trainee has got a clear PDP objectives, they should be able to attain these objectives, and the trust or the organization who is hosting them should be able to accommodate that. And finally, the GMC's goal is to make research activities a core or a customary part of doctor's career. And that is lifelong learning, not necessarily a medical student or undergraduate, but going on to a near retiring consultant as well. The principle promoting research for all doctors. So the first is learning and development. So as a student and trainee, they must be given opportunities to at least observe, not necessarily to do a major work, observe or participate in research during their training, particularly core trainees. And this, as we know that when you're actually trying to help this, so as a supervisor, as a clinical supervisor or education supervisor, you need to know a bit more about it. So you need time to participate in research activities. So that has been acknowledged now, and hopefully there will be some kind of protected time in the future. And there are various learning outcomes for different grades, as I said, and depending on the grade, they should be offered that specific opportunities so that they can master their competencies. And also the doctor should be encouraged to use and enhance skills, the research skills in day-to-day clinical practice, so that it will benefit patients and the organization. So how are we going to encourage this? I think mainly the direct clinical work, the DCC activities, so there should be some protected time for research activities. That's what they're looking at actually, and hopefully in the future we'll have some protected time. And if somebody is actually taking a bit more role, like doing or being a PI in a research project, then they should have more protected time, depending on what role they've taken up, and also there should be enough infrastructure. The organization should prioritize research as a normal expectation for medic and healthcare teams. They also make sure that it's more inclusive, whether it's inclusive for patients and doctors or within the organization, if there are any unmet needs that they could address to. And the most crunch part of this is, one is the availability of the staff in our experience. The other one is the funding. You know, often clinical director says, well, we don't have half a session extra money to just plug into your research activities. That's the common theme that we come across as a working clinicians. So this is what they're looking at. The Department of Health is looking at how this could be protected. And as an organization, top down, that the trust should invest in and incorporate the budget, their financial budget for research activities. So I think that's the core feature, and hopefully in the future we will have some benefit of these policies. So again, there are some barriers for patients. I mean, you can see that some studies patient can't take part in, so that should be addressed. Maybe because they can't travel a longer distance, so that may be a disadvantage for them. And the other thing is, some of the studies are done in specific higher centers, let's say a teaching hospital or a major centers or major hub, where some of them are classed as homegrown studies. So that is a disadvantage for some of the patients. So that disadvantage should be eradicated, or the equity should be there. That's what they're looking at in the future. And if, let's say, there's a small organization where they don't have a big academic unit or big PIs and CIs, so then they could actually use some of their skills and do like a mentoring for the trainees and for the organization itself. And also the we should give an opportunity for patient if there are some new diagnostic tests or some treatments coming up. I think that should be our aim as well. So raising the profile of research activities, so supporting doctors, I think that's the most important thing in whatever stage they are, and there should be facilities for collaboration. So often some of the senior consultant may realize that when they are putting grant, so these days most of the national grants like NHR, MRC, BRC, all those grants. So we have to, there is an expectation that you do collaboration. So it's not just medics, it's a collaboration between various professionals, collaboration between organizations. So you're likely to stand a very good chance of getting the grant rather than just being one single unit trying to bid for a project. And also in the longer term, if people are interested and the GMC's aim is for them to build that academic career and once you're academic leadership, so the expectation is that they're more likely to come up with new discoveries, various clinical trials nationally, internationally, and that will translate whatever the bedside from the lab, the bench, what they call it, the lab to the bedside clinics, which is very crucial, and the translation has to be quicker. That's the aim as well. So as you said, from the doctors within the training grade to consultants, so various programs they can get involved with, and this is what is expected in the future. That should be our culture. I mean, right now there's a huge focus for junior colleagues. There's a lot of fellowship programs, a lot of various, the training facilities, which are done free for a trainee or a younger consultants. But for senior consultants, it's actually a bit overlooked. So the NHR is now focusing on senior consultants, how we could utilize their skills, and is there any specific path they could develop for senior consultants as well. And again, the mentorship, if you have a trainee who is very keen and sadly your unit doesn't have that kind of expertise, so you could actually link up with other trust or academic units, and you could have that mentorship facilities in place. And normally for patients, again, during a routine clinical practice, when you're seeing patients in clinics or home visits, so we should encourage them to take part in research activities, and that become like a normal practice rather than a research worker or a research nurse coming into clinic and explaining the study to them. And again, it is inclusive. So, it's about collaboration between various sectors. That could be industry for commercial studies, various academic units or specialist national hubs. So we're going to get what is called as mental health mission. There will be huge hubs in the region. So they will be like a specialist hubs for, let's say, psychosis hub or a treatment resistant depression hub, things like that. So they're spread across the country. So we should have collaboration with these kind of organizations in the future. And encourage participation, whether it is just explaining a study to patient or actually running a study. So we need to be inclusive for all this activities. And GMC does acknowledge that there is some discrepancies or disparities, and they would like to address these kind of discrepancies or disparities in the future.
So there.
Yes.
Dr. Bonner, can you just wrap up, please?
Oh, yes,
30
okay.
seconds.
So, yes,
we want to have a
sorry,
break.
I didn't realize the time is running. Yeah, okay, we're nearly there. Now, in terms of the trainees, if you have trainees in the audience, so some of you might have seen the new curriculum which was published last month. So the high-level objectives or the high-level outcomes, the very clear objective set for a core trainee by the end of CT3, what they should be doing, and also by the end of ST6, what is the competencies in research. So I've just put the slide in, and that's the new curriculum which has been published recently. And also most of you may be aware of associate PI schemes as well. GMC has acknowledged this and they think it's a good idea, and then they are encouraging trainees to take up these roles. If you need a bit more information about what's available. I'm sure your own team are very happy to help you out. And I've just put some websites there. And this is a reference where I picked up my material from. And thank you for your attention.
Lovely. Thank you very much.
Thanks. Sorry, that was rushed through in the end, but that's
Thanks.
fine.
That whistle stop tour, and it was great to hear from you. So thank you for that presentation. Now I'm just going to address the audience in the room now. So we have a 10-minute break. If you could come back here sharp at 11 a.m., that would be brilliant, as opposed to PM. I don't know why I said 11 a.m. So 11 o'clock, if you can come back here. And we'll resume talking about professional development as our next segment. So thank you very much. Thank you.
Thank you.
Right, welcome back, everyone. Conscious of time, I just wanted to quickly shout out and say, please use your QR codes to vote for the stands, favourite stands, favourite posters. They're on a separate separate bit on your table, so please have a look at that. Without further ado, I'm going to hand over to Charlie and Sally in relation to the Health Education England Population Health Fellow part, and of course professional development and research. So I can see Sally, so I'm going to hand over. And Charlie, welcome. So over to you.
Thank you, that's great. So apologies for not being there in person today. So I'm Sally James, I work for Health Education England in the Midlands. That's an NHS body who is tasked with planning the workforce, education and training of the workforce. So my role is around the public health workforce, the long-term conditions and prevention workforce. And I was involved in the recruitment of the National Population Health Fellows, and we've got Ajali here today, who's the main event. So I'll whip through a few slides and then we'll get to Ajali to hear what she has to say. So in terms of the programmes that Health Education England have in support of development of research skills, I wanted to first say that what I often hear from my public health practitioners working out in local authorities and sometimes in NHS trusts is that they know something is working, but often they don't know how to prove it. They feel there's a link between what they're doing and something else, but they don't know how to check that out. And they worry that in some situations their services are being at risk of being decommissioned because there isn't any evidence of their impact, whereas we know that absence of evidence is not evidence of absence. And we also know, and I can say this because I'm married to an academic, that sometimes the research that is done within academia isn't necessarily definitely aligned to what the service priorities might be, and we need to get better at linking up service priorities with academic research. And we know that there are missed opportunities for people to apply for grants due to lack of confidence in their research abilities and skills. So nationally, Health Education England develops skills in research for public health in a number of ways. So there are the Public Health Higher Specialty Training Programme skills development, that includes a Masters in Public Health. And then we have, for the public health practitioners, the professional standards that they are required to meet to get onto that UK Public Health Register. So those are standards that include things like ethics, epidemiology, analytical methods for quantitative and qualitative data and interpretation, assessing evidence for public health interventions impact, critically appraising evidence of effectiveness, and so on and so forth. So I'll talk about how we support people with that in a moment. And then we have the National Population Health Fellowship, and Ajali will tell you all about that. And that's really great because it's taking people who aren't necessarily working in the public health field, but linking them up with a learning programme and national support to get them working on a research project or get them working on a population health project that is locally a priority. And then we have the Population Health Management Portal, which is accessible to everybody, where there's hundreds of resources for people around things like research. So in the Midlands, in particular, where I'm from, I wanted to briefly mention that I am working with the colleagues in the Northwest around embedding prevention into clinical services. Now, this I wanted to mention because I know that clinicians, from what we've had experience of in running these programmes, were unaware of the sort of the 5-step process in how to evidence their impact, how to be encouraged to publish their research, how to spread what they've done, and they need help in that kind of thing. So this programme that I run with the people in the Northwest is around taking a bunch of clinicians and helping them, sort of almost hand-holding them through the process of using a national toolkit that was originally developed for allied health professionals, but talks you through how to embed prevention into clinical services and involves research and fingertips profiling. So the fingertips profiling is the old Public Health England, the HSC as we're now calling it, profiling data, which enables people to take a population health management approach because it enables them to benchmark against the England average and the best and the worst and their local neighbours. So clinicians weren't aware of that. Then I do lots of upskilling in research techniques, critical appraisal of research, all those things that are mentioned there, and a whole load of masterclasses in relevant areas as well. Now, these masterclasses are to help support public health practitioners and anybody else who wants to get involved in meeting the standards for public health registration, and it includes all of those things. So I tend to get people, experts in the field, or people who are locally available to share their work through these masterclasses, which are hugely popular, and I'm really proud of those. So I also encourage research through commissioning research to influence Royal College's professional standards and to shape curricula. So, for instance, the optometry standards. I commissioned research that looked at the skills around making every contact count and how that could be embedded into the curricula that the optometrists are studying, and that's through influencing their Royal College. The same with health literacy and influencing the allied health professionals and what they get taught. And the same with school teachers, because I don't know if anybody's got kids in the room, but I know that my kids spend more time at school, a bit more of their waking hours at school than they do at home, and actually teachers have a massive influence, yet teachers don't get much of much training, as it were, or enough training around health and well-being, and so it's influencing the teacher curriculum as well. And obviously Health Education England has loads of strong links with higher education institutes, with the academic health science networks, and with the voluntary sector. So the circle that I've put on that slide there also shows the links. Trust the bin men to come now. I'm sorry about the racket. It shows the public health skills and knowledge framework and the links that are in there around the need to work to use the evidence base and to conduct research and provide informed advice that forms part of that key skills and knowledge framework. And that skills and knowledge framework is used when employers are describing or setting up a job description or a person specification or doing a skills analysis of their team. They will be plucking their skills and their knowledge out of that framework, and that includes research. So it's absolutely key. And then just briefly before I finish, I wanted to just show this slide, because this is one that I fling out wherever I go, because it's to encourage the practitioners to think about their whole career. And what I wanted to point out is we make a big deal about pushing them to consider things like PhDs, research opportunities, linking in with research projects, etc., as part of their overall growth. So I just wanted to put that there. And that's me. It was a whistle stop talk, so I know we need to get straight on to Ajali. So happy to take any questions. Yeah, thank you very much for listening. Thank you.
Thanks. Thank you very much, Sally. Were there any questions at all from the audience, panel's members? Okay. No, doesn't look like it. So thank you very much, Sally. I'm going to hand over now to Ajali.
Brilliant, thank you. Hopefully you can all see my screen okay.
Yes.
Fantastic. So good morning, everybody, and thank you for the invitation to share about my fellowship experience over the past year. So my name is Ajali Yusuf, and I am just coming towards the end of my population health fellowship year. I technically am the East Midlands fellow because I'm the only fellow in the East Midlands, as far as I'm aware. Everyone else seems to be scattered around the UK, and it's just a brief overview really as to my experience of the year so far and some learning that I've obtained over the past year. So I am currently a pharmacist working in primary care in Nottingham. I also do some other things in terms of working with NHS 111 in Derbyshire, but my primary role is as a primary care network pharmacist in Nottingham. My host organisations for the fellowship year, so that's the Population Health Fellowship year, the University of Lincoln, so the International Institute for Rural Health, and Lincolnshire Partnership Foundation Trust. It really has been a year of growing and increasing in my knowledge on health inequalities, population health, the wider terms of health. I could keep going on and on and on, but it's been a great year of just learning personally, professionally. And one of the big things that I knew of, but I think until you experience it, you don't quite appreciate, but the networking opportunities throughout the fellowship year have been fantastic. And also I guess the opportunities to disseminate learning at conferences such as this, but also at the Health Service Research Conference that took place back in July. So those opportunities have been endless and have been fantastic for me, and personally and professionally. This is just a brief, apologies, it's a busy slide, but it's just a condensed version of the Population Health Fellowship curriculum and the things that we were, I guess we were shown either through our population health projects with our host organisations or taught by Health Education England, who had some taught components to the fellowship year. We as fellows, we would meet once a month on average. Initially, we met a lot more frequently, and we would have sort of specialist lectures and sessions from experts in the field of public health and population health. And they also provided, the fellowship peers also provided us with online learning and opportunities for develop with regards to these areas of the curriculum as well. So throughout the fellowship year, you're encouraged to undertake a fellowship project. And this was something that actually at the start of my fellowship year, I had a conversation with both my host organisations. And we had a choice of projects that we could choose from. And I went with one that I guess would be new to myself, would challenge me, and is outside of my area of pharmacy, which I felt was a good challenge and growth opportunity. And my fellowship project follows on from work being undertaken by colleagues at the International Institute for Rural Health and LPFT, looking at staff experience of the use of telehealth in delivering IAP services. So that's improving access to psychological therapies. My project was to look at service user experience of the move over the past couple of years of an increased use of telemedicine in delivering these services from a service user perspective. And it's been an experience. It's been great. It's been my first time undertaking semi-structured interviews, either face-to-face via telephone or online. And actually having that experience and developing my understanding of qualitative pieces of research. My project is a service evaluation, but those skills and those tools necessary to be able to undertake interviews such as this has been amazing. Some of the initial findings from some of the interviews that have been taken so far are, the accessibility of telemedicine. A lot of the service users have mentioned the ease of it, and actually how their physical health status has had an impact on whether or not they would prefer to be offered a virtual telemedicine option of an appointment. Often a blended approach was mentioned by service users, but also I think one of the key learning points for me was the need to factor in service user preference and the type of appointments that we offer to them. And when I mean type, I mean whether it's virtual, face-to-face, a combination of both. And also another key learning point so far has been how we communicate with our patients, our service users, the population outside of sort of medical appointments or therapy sessions. What's our communication like with them? Is it via text? Is it via email? Is it via letters? And actually, is it suitable still, the ways that we communicate with patients, is it suitable and appropriate for those patients and service users? Or actually, do we need to start tweaking things a bit more, especially as we use telemedicine approach to delivering healthcare a lot more within the health service? For me, the development opportunities, like I said, have been endless, and I could go on and on and on, but these are a few key things for me. Successfully applying for the first time ever for an ethics application and having that approved after a few sort of questions and points of correction. So that was a great experience leading on that. Developing my learning and research method skills, and that was something that was facilitated through the University of Lincoln, and very grateful and appreciative of support from my supervisors at the university. Funding from LPFT, to attend and present at the Health Service Research Conference in Sheffield, which was back in July. And that was such a great opportunity to share research findings for the team at the University of Lincoln, but also to be part of a research group, just being around others, disseminating their pieces of work. And I guess was a first face-to-face conference that most of us have been to in the last 2.5 years. So just really great to, I guess, bask in all that research and knowledge. I joined the Lincolnshire Research Development Forum as well, and I presented alongside the university team to the RDF. I'm hoping through my service evaluation to be able to provide a series of recommendations to LPFT and hopefully write up and publish service evaluation findings as well. Reflections from my year. It's been a great year of, as I mentioned at the start, just networking with colleagues, meeting senior leaders of acute mental health trusts. I've had the opportunity to lecture at the University of Nottingham, giving a lecture on health inequalities to the undergraduate pharmacy students. As I mentioned, presenting a poster and also attending the HSR conference, so also presenting a poster and oral presentation on behalf of the university and LPFT. Meeting with and discussing with NHS England Health Equity team in the north, also meeting with AHSN colleagues to discuss mental health and my IAP project at the very start of the fellowship year, engaging with public health colleagues who have been really gracious with their time and sharing their learning, population health and health inequalities colleagues as well, both in Lincolnshire and in Nottinghamshire. And as I mentioned at the start, it's just been a year of professional and personal growth. One of the big things for me was my confidence in terms of the world of, I guess, research, academia, but also population health. And I found that through my learning and development over the past year, that's definitely grown. And the impact for me on my clinical practice has been understanding 420+5, understanding health inequalities, understanding health, population health, and being able to bring that knowledge into my workplace and sharing that with colleagues through joining my PCN Health Forum, joining the Nottingham City BAME Health Inequalities Working Group, and providing, some of the knowledge that I've learned into those spaces and supporting colleagues with work. Having a greater understanding of the wider MDT, how does public health, population health fit into clinical practice, and also it's impacted my day-to-day interaction with patients that I see in clinic, and also utilizing research skills in my clinical practice as well, and using that to support evidence-based practice in my clinical role. And what next? As I mentioned, hoping to complete and write up my project, continue to utilize the knowledge gains to, I guess, empower my colleagues and to share with them and disseminate information to and with them. I'm currently supporting some work around primary care workforce racial inequities. So that's in Nottinghamshire. So continuing to do that and writing up another piece of work that we've done and are doing at the moment. And continue on in research. Through and because of this fellowship here, I have had the opportunity to grow in my research skills, as I stated, but also I've come across a PhD opportunity at the University of Lincoln, applied and have been successful in it. So I guess one of the things I really wanted to encourage everyone on the call, both employers, trusts, colleagues, was just around, I guess, for employers seeking opportunities like the fellowship opportunity and really sharing that with your workforce. I think it's a great way of upskilling your workforce, also giving them something different to do as part of their day-to-day job, but also potentially could impact on workforce retention as well. And for colleagues, it's just a great way of learning. You're supported, you're given, you've got funding to support your work in this place. You also got the space to engage in research that's protected for you, and you learn so many new skills and you meet so many amazing, interesting people who add to your learning and development as an individual. So I would say that I'm very grateful and thankful to all the different people who have supported me over the past year, from my host organizations to my employing organization. And thank you all for listening. Happy to answer any questions at all. My contact details are here. Should you want to email me, I'm happy to answer any questions.
I just wanted to thank the two speakers, Sally with setting the scene, and then Ajali to talk about your own personal experiences. And I do remember the interview. I think Tracy was in as well, and how well that enthusiasm shone through. And it's great to see you at this stage now, having had the experience and having developed it, and talk so well about what that's all about. I mean, I would say as a plug, when this opportunity does arise, it'd be great if we can have, excuse me, it'd be great if we could have members from our organisation really think about applying for the HE Population Fellow. So I'll just ask, are there any questions at all for either Sally or Ajali in the audience? I don't know whether there's anything in the chat. We've got a question.
Really more clinical, like, you know, how that will impact it on the clinical work if you get the fellowship. It's a practical.
I don't know whether you heard that, Ajali, but the question was, I'll let you state that.
That's my question, really. How that will impact the clinical work that you are doing when you're, if you are lucky and get the fellowship.
So is that the impact on my clinical work? Was that the question?
Yes.
I think
you have like kind of equipment, or you have to use your clinical work. So I don't know how that will work.
So, sorry, could you just say that for me again, Jazz? I didn't quite catch the last part.
Yeah, sorry. I think the question was, how has the fellowship impacted on your clinical work? Is this a question specifically about backfill, or is it about clinical experience and keeping up to date?
No, I mean, like, if you are working full time
Mhm.
and then you're successful to get the fellowship, so how that will work? Like, you know, will you exempted from some of your clinical duties to do the fellowship? So that's
Okay.
it.
Yeah. So I guess it's about having that conversation with your employers as to, you know, what are the best days in terms of taking time off, because the fellowship is 2 days a week. Tuesdays were pretty much compulsory because that's when we had the national teaching organised by Health Education England and the Academy of Public Health back down in London. So there was one fixed day, but then the other day was more of me having a conversation with my employers and saying actually what other day works best, and also having a conversation with my host organisation saying what days work best. Fortunately, my host organisation were quite flexible, and I was able to have that negotiation with my employing organisation. And on those days, unless something critical happened, and COVID was probably the most critical thing at the time, that time was protected and you just focused on your project with your host organisation, and your funding. So your organisation, I guess, could use the funding, or the money that they're not paying you anymore, because the rest of your employment costs were covered by Health Education England. They could use that to backfill somebody else if they saw fit. But that time was definitely protected for me, but others have had different experiences. But I know for me, definitely that time was protected. Hopefully that answers your question.
Yes, thank you.
That's a great answer. Thank you. I'm looking around. I don't think there are any further questions. Question in the chat. Thank you. So we've got a question. Can you give us a link on how I can learn research skill on HE England, like statistics and data analysis? Good question. I wonder whether that's one for Sally in terms of linking in.
Yes, of course. Yeah, happy to receive emails, and I'll put my details in the chat, and then I can point you to all the right resources. And I can also send them to Sandra, and she can send them out to people on in the room. That helps.
That's very helpful, thank you. And the other thing I would say is, as a plug for what we're doing, we do have a Research for Everyday Clinicians, in effect, course that we've started within the postgraduate network. So please utilise every opportunity you can within and externally in the trust, beyond the trust, beg your pardon. Thank you. So that was brilliant. Thank you very much. I'm now going to hand over to Spot On Time to Maria Rawdon, who's going to be talking about her experience on applying for PhD funding.
Emma.
Oh, sorry. Beg your pardon. Beg your pardon.
Sorry about this. Just get your slide.
Step away. Thank you.
Where are we? Keep going.
Yeah.
Sure.
Yeah, there you go. It's the grey one.
That one.
Yeah.
Bro. Share. Sorry, everybody. Truly online and
Yeah, it's very hybrid.
very hybrid. There we go.
Good.
Super duper. Okay.
Thank
Watch
you.
you.
Yeah. Some added bonus, isn't it?
I know.
So hello everybody. Thank you for inviting me, Tracy. Well, blame Tracy's fault if this all goes very wrong. Marie can't be with us today, so hopefully with the click of a button she'll appear by video at some point. So my name's Emma Rowley. I'm the training lead for ARC East Midlands. So ARC is part of the NHR infrastructure in the across England. There are 15 of us, and we have two responsibilities. The first is to do applied research that will benefit patients and get into practice. And the other is to build capacity amongst the research workforce and the non-research workforce to both undertake and use research evidence. So I'm going to give you a quick whiz through an ARC, tiny whiz through an ARC, talk about some of the professional development opportunities that we offer, and then link you to Marie, who's going to tell you about her research journey and how she came to be part of the ARC from being a nurse within this organisation. So ARCs were clerks from 2008 onwards, and the NHR in their wisdom decided to change their name in 2014, just when people thought we weren't a shoe shop. But anyway, so we are local collaborations between HEIs and NHS providers and commissioners and industry partners and patients and everybody in a co-produced sense, tasked with getting research into practice and doing meaningful research rather than the ivory tower academic research that some people have been talking about today. There are 15 ARCs across East England. We are the East Midlands, and we cover one of the biggest populations of any of the ARCs. So yeah, there's loads of information about ARCs. Please do ask me if you're interested, but it's not the main purpose I wanted to talk to you about today. The way we tackle our capacity development primarily within the East Midlands ARC is to support PhD studentships. To date, we have awarded, through our academic partners, 28 PhDs, both to traditional researchers and to NMAP clinical academics, so those nurses, midwives and AHPs that we heard Kate and Joe talk about this morning. We said in our current grant licence bid that we would support 40 students, and we're well on our way to doing that. So we currently have 49 trainees on our books, including 10 legacy ones from our Clark funding. And about 50% of those are clinical academic NMAPs. So we also took a strategic decision that we were going to support NMAPs and not doctors to do PhDs for a variety of reasons. There is I guess, as we heard from this morning, hearing about the nursing and the AHPs and then the GMC position, there is a bit of a tension between those different occupational groups about who has it better and who has it best. Traditionally, the NMAPs have always said they don't have enough opportunities versus the doctors, hence why we as an organisation chose to support that occupational group rather than medics. Our funding, we have two funding models at present. All of our studentships, though, are RC UK or UK R&I stipend levels. So they are very basic stipends, which are, whilst tax-free, are never going to make anybody rich. And there is debate at the moment whether or not it actually staves off poverty. So it's about 15.5, 16, 17 grand a year to do a PhD, which isn't attractive for practitioners who are on full-time salaries. The other funding model we have is a 50% funding model. So we only provide 50% of that funding, and then either the organisation that's hosting the PhD, the trust somebody comes from, the charity they work with, or a kind of a jigsaw of all of those approaches needs to put the rest of the money together. It's about partnership working and building capacity in a workforce, and it's really useful and valuable from an organisational perspective rather than being seen to be just being funded by an external funding body. There are loads of benefits from being an art PhD student. You get to work with our own PPIE networks rather than just your own. We have dedicated funding. Critically, as part of the NHR infrastructure, we can link students into the NHR Training Academy, which no other fund would ever be able to do, and they have some pretty amazing opportunities. So one of our students has just gone down to Great Ormond Street to learn about a WYSI laboratory technique that I don't understand in the slightest, but he assures me it's going to be career enhancing. But why should you as an organisation invest in PhD students? So it's about, as we've heard earlier, research is about creating evidence bases for local issues. It's about research that directly benefits patients, but it's also about investing in that culture to grow capacity and capability and to create those leaders of the future that Joe and Kate were talking about earlier. It's about reputation and growth. And it's also about income and investment potential, because actually your staff will be able to go out and bid for those big funding applications and funding grants, rather than letting those sneaky academics steal them all. I am an ex-academic, it should be said. It's my disclaimer. But it's also about being realistic. Don't expect those people that you support to do PhDs to quickly implement something, because a PhD doesn't directly lead to implementation of innovation. It's actually an academic route to being an academic, but you can pull some of those skills back into practice. Any change that comes from a PhD won't be quick, nor is it likely to be visible, but actually it's about building that confidence and that capability in individuals so they can come and lead from within and build capacity amongst their teams. But it's also thinking about, what do staff want when they come back from a PhD? They're not going to want to come back and do the job they were doing previously. So there needs to be some investment and some career progression for them. So we don't know what we're doing for the next intake of PhD students. Our funding call will come out in probably January 2023, but this is what we did last year. So we offered £31,500 towards a what was a £62,500 studentship. UK R&I have increased their studentships as of next week, so we will be enhancing our model. It's only going up £1,500. It's not going to create that much difference. Ours are open competitive calls. They must be applied research, and our subjects must be linked to our substantive research themes within the ARC, which we have 6 of them. But we ask people to get in touch with us before they make an application, because there are certain research topics that we just cannot support because of the way that we are licensed. And this includes any drug or cancer related research. So if anybody is interested or knows somebody wants to do a PhD with us in the future, please do get in touch before you start making an application, because I'd hate you to waste that time for me to turn around and say, I'm really sorry, you're not eligible. I'm not even sending your application off for shortlisting. We also ask that the PhDs that we support are hosted in any of the East Midlands HEIs, and there are 8 of them. So as long as it's one of the East Midlands universities, as long as it's doing applied health research, it's pretty broad. As I said, there are greater benefits of being part of the ARC, which maybe other funders can't have. And the key thing is that link into NHR infrastructure and the NHR Training Academy, who offers some amazing training courses which go over and above what HEIs will provide, but also gives really great networking opportunities too. So these are some of our legacy successes about what happens after you've done a PhD. So we've had people implement national service change. It has to be said, this is a one-off and it very rarely happens, but it does prove that it is possible. People have joined government advisory panels. They've gone on to win personal fellowship awards at postdoctoral level. They've advanced their careers. So we've got clinical academic research, we've got consultant posts now, we've got service managers. Marie, who we're about to hear from in a minute, she hasn't even finished her PhD yet, but she's now got a lectureship post. Or we have people who have gone on to win more bridging awards. So we're really lucky in the East Midlands that it's not just about there's a bit of funding here, there's a bit of a fellowship opportunity there. There is a pathway to support people. It's primarily funded in a piecemeal fashion, and collectively we have created it into a pathway. So it's the ICA, or the Integrated Academic pathway for NMATs. And currently Lincoln holds the funding for the internship model that comes from HEE. Nottingham holds the pre-doc fellowship for HEE. ARC offers the PhD funding, and then Nottingham again hold the postdoc funding. They're bridging awards and get people in the right place to apply for really good competitive national funding. So our postdoc offer across the East Midlands has to date been to buy out people for a day a week to develop their CVs, write their publications up, be the best possible applicant they can, do their co-production work with their stakeholders and their PPIE representatives. So when they go for national awards, they stand out and they are the greatest calibre applicants possible. From an organisational perspective, it's a tiny investment in that person. It's up to £20,000 in a year. But actually, before we started doing this, there was one NIHR postdoctoral fellow in the East Midlands. Now we have 11 of them. So it shows that a bit of investment in people to give them the credibility to start knocking on doors, asking questions, asking for support really does help. But before we get to that stage, ARC can also offer the opportunity for placements and internships. So if anybody wants to come and learn what it's about to do research with academic teams, come and ask. We're really happy to host you. We all do still work pretty virtually. So it's not like we're going to say, yes, please come to our office in Lincoln or come to our offices in Nottingham or Leicester. But there's things we can do to kind of share what we as academic researchers and applied researchers do on an everyday basis. We also host or are part of some really influential networks, which we're really happy for you to all join if possible. So there's the East Midlands Clinical Academic Pathway, which we've just spoken about. If you have questions, we can link you into that group. For the NMAP colleagues amongst you, you are more than welcome to join our East Midlands Clinical Academic Practitioner Network, which is a peer support forum, mostly virtual at the moment, it still has to be said, but it's people who are starting on their clinical academic journey and just want some support and ask maybe what they think of the silly questions that everybody knows aren't the silly questions, really, they're the quite insightful questions, through to professors who have been there, done that, and now want to start nurturing and sharing. So yeah, if you're interested in that, drop me an email and I can sign you up for it. And then also I can always share information back into trust through Tracy from the NIHR if you don't already get it. As an ARC, we have traditionally shared short courses, which you as one of our member organisations are welcome to come and participate in. They're short, snappy courses, primarily delivered online, mostly research skills or operational type research and impact skills. We haven't scoped the programme for next year, so if you have any burning needs that aren't delivered locally, that the University of Lincoln won't deliver for you, come and ask me and I'll add you to my list. Can't promise we'll deliver it, but we'll give it a go. So that was a snapshot of what the kind of things ARC offered, purposely really quick and really because I want to introduce you to Marie. So Marie came to ARC, I don't even know how many years ago, a few years ago, and said that she wanted to do a PhD. And it was a bit of a struggle to get her some funding, but we got her some funding in the end. And as she'll describe to you, what she did before she came to do a PhD, and hopefully what she's going to do after it. So I'm going to hopefully press a video and she's going to magically appear, is the idea. Yes.
Someone's pointed out attention to
Oh, she did not use it. There we go.
Okay, I'm just going to mute myself so we don't have too much echo in the room.
It's okay.
Are you going to increase your speaker?
No.
No way. I do mind then.
Online, can we ask those online to mute, please? We can hear you in the room. Thank you.
for funding. And within that, maybe some hints and tips and bits and bobs if anybody's interested in applying. So please do. It could be the best thing you ever do. And then right through to kind of where I am now with it. So hopefully it can make sense when we get to the end. So hello, my name's Marie Rawdon. I have been asked to talk to you today about my experience of being an NIHR East Midlands PhD student. And hopefully this will make some sense as we go along, but I found it quite tricky to put onto slides the experience in general, because it's been so amazing, and I've learned so many things, and you know, certainly personally and professionally I've changed so much. So I'm going to start, I think, at the very beginning of applying for funding. And within that, maybe some hints and tips and bits and bobs if anybody's interested in applying. So please do. It could be the best thing you ever do. And then right through to kind of where I am now with it. So hopefully it can make sense when we get to the end. So I guess right from the very beginning, when it came to applying for funding, the important lesson I learned was about being prepared, having everything ready to go. Once the funding call comes out, there isn't that long to have a proposal ready. So you kind of want to have something in mind before then, really. And working really closely with your kind of clinical and academic kind of colleagues. So I was very fortunate in so much as I had been in post as a early career researcher with the LPFT research team. So for that, one day a week I was spending at the University of Lincoln working on a systematic review. And that enabled me to kind of develop some of those academic networks, and indeed those wonderful people that I met became part of my PhD supervisory team. So having people right from the get-go that are willing to support, mentor and tutor you throughout your PhD before you even start is really, really, really important. So have a study in mind, have a draft proposal ready. You can always tweak it, change it, and do whatever you need to do to it near the time. I attended funding bid workshops left, right and centre, and NIHR funding workshops, not just random ones. I had to think about how I was going to cost my study, which is something I wouldn't have thought about before. So how am I going to pay participants? How am I going to pay for dissemination and events and those sorts of things? So I'd kind of contacted the clinical research network to talk about how I cost a study with someone from there. And I'd also been to various different kind of academics and clinical professionals as well, around their kind of take on what things should be included. I'll miss the plan for change bit, I think, until last, but in terms of PPI, so public and patient involvement, that for me has been absolutely the crux of this whole study. So right from the beginning and right through now, we're just at data analysis point now, so we've collected our data. But I've been holding regular stakeholder meetings with all of my people that I've gathered along the way for PPI. And those are clinicians, people with lived experience of an eating disorder, service managers, academics, research team, extraordinaires from LPFT, and all of them have brought something wonderful to the table. They've all helped shape and support the study. as we've kind of gone along, right the way through to from consultation on body models that we were showing participants, through to kind of day to day, how do we promote the study within the trust and those sorts of things. So I've been holding those had been holding those sort of fortnightly-ish, and that's been working really, really well. When you're coming to kind of submit your funding application, remember also when you're kind of working on who to include and who to ask for support, be brave, ask people that you may not have ordinarily thought of or been brave enough to ask before. So I'd emailed the then Chief Executive of LPFT to ask very nicely for some research cost money, which I was granted. And again, I have to say a massive thank you to LPFT for that. So that's enabled me to pay my participants for taking part, and it will support in the dissemination of our findings. So yeah, plan for change. Something I hadn't thought about doing, and I'd got my plan, I'd got my ducks in a row in various shapes, sizes, from various different walks of life. I'd got a peer-reviewed application that had been given funding by the Archives Midlands, and I remember my mentor at the time saying, "This, this study isn't going to be what you think it's going to be. It will change." And ridiculous. I've got everything lined up. I've got my study ready to go. Let's go to ethics. Let's get on. And then COVID happened, and we couldn't obviously recruit participants. We didn't know what was happening. We certainly couldn't recruit physically compromised participants in terms of cross-contamination. We couldn't use a virtual reality headset, so everything had to go back to the drawing board. How are we going to run this study? So I went from having ducks in to having squirrels today. And I kind of learned that that's part of the process as well. Whether it had been COVID or something else, hopefully not as monumental as COVID, that part of the learning experience of a PhD for me hasn't just been about the academic kind of skills and development that I've learned along the way, but it's also been about personal reflection and kind of growth as well. That just accepting that's going to happen, it's going to be part of it, taking a step back from it and thinking about how we can just kind of calmly move on from it. So very much around learning from adversity, and part of learning from adversity for me has just been the fact that I've accepted it's going to happen. So there will be barriers, there will be change. I just accepted it as part of the journey, and looking very much at setbacks as a learning opportunity. What can I take from this? Yeah, something may not have gone as I thought it might, or is that because we're missing something? Do we need to tweak something? Do we need to do something different? Which actually is kind of what research is about anyway. Use your team support. You're not alone. My stakeholders were really, really supportive of all the trials and tribulations that have gone on throughout the study. So not only have they given me their input as to what works in practice and how we can make it meaningful on the ground, as it were, but they've also supported me with any kind of bits and bobs that have kind of come up as well, and to just keep going. That's just really an important thing to do. And to keep going, you need to think about your support systems. Again, probably wouldn't have thought about this too much before COVID, but it's one of the good things that's come out of COVID is having that kind of self-reflection. So personally, it was about being realistic and being very, very honest, being honest about my time, what support I've already got versus what I already what I might need. Creating time for myself. I don't think any of us are really good at it. I'm particularly terrible at it, but I have got better. And again, that's as a result of managing my time doing this study. Professionally, the support that you've got your supervisory team. My supervisory team have been absolutely amazing and continue to be so. In terms of the service, LPFT were again amazing. They, without any questions or hesitation, offered the research cost money. They allowed me to reduce my hours to enable me to undertake my study. They provided me with stakeholders, provided me with admin time. So yeah, so again, massive thanks to LPFT. There's university training opportunities. That's been really helpful for me as well. So things that I thought I might need to brush up on, some of the research skills, sort of modules, and sort of qualitative interviews and writing critically and all those sorts of things that have been quite helpful to dip into just to brush up on. And HR training opportunities again been really, really helpful, and something that's readily accessible and promoted within that support service. And postgraduate networks. So who can you link in with? Who's going through it with you, and get in the same boat as somebody else. Also, I guess linking into kind of support networks is identifying your champions. Identify your champions and treasure them forever. Your champions, or my champions certainly, have been really, really helpful at getting my voice heard in places that I can't be, attending meetings and forums that I don't have access to, but really promoting the study, promoting what we're doing. And that's really facilitated the support then that we've received back in being able to actually crack on and do things. So that's been very much linked to service buy-in. Your champions will help you with funding opportunities. They know they've got their ear to the ground, what's available. They're on your side. They want you to kind of do those things. They help with study management, ethical approval processes, mentoring, and the dissemination of your findings. So again, these are the people that are shouting from the rooftops the things that you have managed to do, or things certainly that I've managed to do. It's a shame I can't be there today to embarrass a few people on who are my champions, but there is a massive, massive long list. Certainly all of my stakeholders, and definitely Tracy McCrainer and Emma Rowley. So thank you very much. So where am I now? Well, very much, I think, in a bit of still of a period of transition between kind of clinical practice and the world of kind of academia. But I've completed a systematic review and meta-analysis, and that's due for publication. That's on the efficacy of technology-based interventions in anorexia and bulimia nervosa. I've developed a research protocol twice. I've collaborated with my stakeholders and kind of learned how to kind of keep that going, and the importance of that. I think I've talked about it quite a lot. I've conducted a randomised control trial, which I thought would be impossible for me, but there you go, I've done it, and I feel really proud about that and quite excited to start looking at my data now that I've collected. I've conducted qualitative interviews ready for thematic analysis, and that's around the acceptability of the study that we implemented. I feel okay with going to NHS ethics with my application and the process around that, because it's not that scary and it doesn't take that long. Feel okay about writing for publication again, which probably wouldn't have done before. And now, thanks to those kind of, I guess, skills and that journey that I've been on, I've been asked to collaborate on an extension of the study that we conducted, and that's with Birmingham City University and Northumbria University, which we're due to run within the University of Lincoln shortly. We have approval to go ahead and do that. I've also been recruited as a nurse lecturer with the University of Lincoln, which I'm really excited about. And again, a massive thank you to UOL for their support over the last few years, but also continued support as they kind of are now enabling me time just to wrap up and get things finished. So massive, massive thank you there as well, and acknowledgement. I would just like to say that that's all. Thanks to the NIHR and the funding that I've received. None of this would have been possible without. So if you are interested in going ahead and do that, then by all means, it would definitely, like I said, change your life and take you on a completely different direction. All the things that you'll learn, but again, all for patient benefit, all for the betterment of service delivery. So I want to say thank you. If anybody wants to contact me, please feel free to get hold of me at mrawden@lincoln.ac.uk. with any questions. Also, if you're interested in applying for funding, I'll happily talk to you all day long about the process there as well. So thank you.
Sorry, everybody.
Joy of the hybrid conference.
That's the end. There we are. So, what is joint dementia research? Listen up, if you want an echo dot. Well, essentially, put in simple terms, it's just a platform where people who are interested in taking part in memory-related research can register their interest, a little bit like the vaccine register. Anybody over 18 can sign up, and there's a misconception out there that you have to have dementia in order to sign up. That's not true. Anybody at all, with or without a diagnosis of dementia, can sign up. It was developed by the National Institute of Health Research with the Alzheimer's Society. It's been there for quite a while. And the other part of it is that researchers who are taking part or are running dementia trials can also put their studies onto that. And the impact is that if you are eligible for a study and you're registered, it will alert you that that opportunity is there for you. How it fits in with our work? Well, as a research team, if we are supporting recruitment to a dementia trial, we are given a list of everybody who is eligible for the trial in Lincolnshire, and we can contact those people and tell them about the opportunity that's available to them, ask them if they'd like us to come and translate the information sheet for them, because sometimes they're quite written in academic language, and to provide a personal support for people that we go and see. So we'll sit with them and we'll problem solve for them. We will liaise with the study team. We'll make it an enjoyable and easy experience for them. Obviously, the more people that we can get taking part in research, it brings us closer to finding a cure, which is our ultimate aim. So what was the driver to develop the Lincolnshire Joint Dementia Research Advocate Programme? Well, in 2019, the Joint Dementia Research National Team disbanded the Champion Programme. And they disbanded it for health and social care professionals. Anybody who was not professional, for example, a member of the public not employed by a health and social care organisation, was contacted and asked if they would like to be a research champion with a wider remit. And that kind of left a gap, because it seemed to us that health and social care professionals were best placed to talk to people about registering on the Joint Dementia Research platform. Also, for the JDR Champion Programme, no organisation was allowed to register as a whole. And again, this seemed like a big gap in the offering. Part of my work at the time was to run a couple of pilot programmes for the Clinical Research Network to engage social care providers in research. And I was constantly being asked by social care providers how they would provide evidence for CQC that they were supporting JDR. They were telling me that we're doing this, but what evidence have we got to show our activity? And I went, oh, there isn't any. At the same time, last year, I was asked to pick up the JDR remit, which runs in the research team here at LPFT. And one wet Tuesday afternoon, just prior to Dementia Action Week, 3 of us got together from the team. So it was my colleague, Rachel Fothergill, Tracy Collishaw and I. And we said, well, Dementia Action Week's in May. We really need to boost recruitment to JDR because we're just coming out of a pandemic. So let's aim to recruit 300 new people onto the register. And we came up with the strapline, links JDR 300. And so for 3 months over Dementia Action Week, I can't tell you how hard we worked. We were just about putting an application for funding for shoe leather, weren't we, Rachel? Because we posted paper registration forms through letterboxes. We attended every meeting that was going. We had screensavers. We did everything, and we worked our socks off. And during that period, we recruited just over 100 people. And everybody told me this was great. And I was really disappointed because I wanted 300. So around about June time, because the Dementia Action Week's in May, I thought, right, we'll stop now and I'll do a bit of evaluation. And when I first wrote this, I put the evaluation was to do nothing. And that's not quite true, is it? Because you watch and wait. So we stopped the promotion, watched and waited what happened. And recruitment went right down from about 30 a month to 4. So this made it clear that getting people to join dementia research and to register their interest is not self-propelling. This is something you have to work at quite hard, and there are various reasons for that. So I decided that what we needed was a wider footprint. So with the support of my manager, Tracy McCrainer, I wrote a proposal for a Lincolnshire-led and Lincolnshire-managed joint dementia research programme pilot. And we put this to the national team. And I have to say they were immensely supportive, and we got that approval. So what were the aims of this? It was a shared goal for health and social care professionals. So this advocate programme is specifically for people such as yourselves in health and social care. What we wanted to do was to bring social care and NHS research together, because this was one of the higher level objectives for the Clinical Research Network. The Clinical Research Network pay my wages and a lot of the wages for our clinical research practitioners and research nurses. So it fitted quite nicely with that. Clearly, we wanted to increase registration numbers because that means that we can get more people involved in research and work towards finding some kind of a cure. Part of my remit for dementia research is to approach study teams and say, hey, would you like some support with recruitment? Please come to Lincolnshire, we can help you. Now, Lincolnshire's not the first place that study teams think about when they're running a research project. The first thing that they think about is Nottingham or Leicester, because there's a denser population there. They tend to think of Lincolnshire as being very flat and we grow cabbages and it's got a sparse population. And why on earth would you want to do that? So when I approach study teams, I have to have a really good offering. I have to be able to sell Lincolnshire to bring research here. And to be able to say that we've got a group of people here who are really keen to promote joint dementia research and to take part in research is something that I can now offer to these study teams, and they'll go, oh yeah, I never thought about Lincolnshire, but yeah, okay, then we'll give you a go. I wanted to improve lines of communication. We all work in silos across the piece, let's be honest. We're all busy doing our own thing. Communication with other trusts or social care providers is sporadic. We try really hard, but we've all got our day jobs. And I really wanted to bring together a collective of people across the professional workforce in Lincolnshire and get us talking. And I wanted to improve specifically the conversation about memory research, because at the moment it's like a couple of weeks a year, and that's not good enough. We talk about it and then we forget about it. And I wanted to have some way of keeping that discussion and conversation going all the time, because all the time people are having a diagnosis of memory loss. So what is it? Well, it's managed by the research team. It's specific to Lincolnshire. It's not a national programme. It's just us, and we manage it. And that's great because it gives us a little bit of control about it. We've got a list of advocates when they come forward so that we can contact them. We're going to have meetings 2 or 3 times a year. We've got an WhatsApp group, and we're planning an annual conference in March. We produce regular newsletters to all our members on memory research activities, events and networking opportunities, because I'm really keen that we keep the energy going with this and they talk to each other. And we give them advice on how to get free JDR promotional material, because there's absolutely tons of it out there and it's all free. We give them a certificate and a welcome pack with little goodies in. And it's open to individuals, teams of people, or whole organisations, which makes it a little bit different from the Champion programme that existed before. And we've been asked to produce a report on the pilot for the JDR national team, because they're watching this quite closely. And if it's successful, they're saying that it will be rolled out as good practice a little bit wider of national teams. What do we ask about advocates? Well, they agree to register themselves on the JDR website. They agree to complete the JDR Learn tool. That takes about 10 minutes. It's online. We can offer Dementia Friends training as an option. Now, Dementia Friends training is terribly popular with our care homes, isn't it? Poor old Rachel went out a few months ago to deliver Dementia Friends training in one of our care homes, who were an advocate. Expected to find about 10 people and had about 50. So it's really popular and it's great fun. And care homes absolutely love it, because it can be rolled out to family members and staff. They agree to promote registration to join Dementia Research, and it's free, doesn't cost them a penny. So we had a launch event in May. It was online because of COVID restrictions, and we had 70+ attendees. So that gave us an inkling that we're actually pushing an open door, that people wanted this. We had presentations from Steve Roberts, who's the Associate Director of the Older Adult and Frailty section for LPFT, from the National Joint Dementia Research Team, and I did a little introduction. We did spotlights, which was very close to the Eurovision Song Contest, and it did kind of dissolve into coming Azerbaijan about halfway through, but we managed to get through it. And we asked people on Teams to do a little couple of minutes saying who they were, what they would do, what their job was, and why they were supporting JDR and wanted to be an advocate. And we had spotlights from all sorts of fantastic people, with our chief exec, care home managers, home care providers, University of Lincoln, LCHS, direct delivery team, to mention but a few. So already we're starting to see that this is bringing together people from various professionals, all talking with one voice. The evaluation, again, watch and wait. What's happened has been phenomenal without any work from us in particular. We have all these people here who are advocates, have expressed an interest in supporting the programme. You will see that there's a broad range of health and social care professionals who have come together to join us with this programme. It's clearly something attractive and something that they wanted. So Age UK, Lincolnshire and South Lincolnshire have expressed an interest in developing a formal collaboration with our research team to bring research into their daily work. Steve Roberts has invited the research team to be part of the Integrated Care System Dementia Programme Board. This is fantastic. This means that we get research in there at the beginning. Karen Christa, who is head of transformation and workforce development, hope I've got that right, has invited us for exploratory talks to be part of LPFT's trust induction. I tell you, for the last 12 years, we have been trying to be part of trust induction and it hasn't happened. Fabulous. The voluntary services sector and the University of Lincoln Medical Students Voluntary Board have contacted me and said, can we work together? The whole of the voluntary services sector in Lincolnshire and South Lincolnshire is a Lincolnshire JDR advocate as you know, a whole organisation. We've got the direct delivery team here from the CRN. Very pleased to meet you. All advocates of all, the 3 of them have joined up. We've got representatives from the LCHS research staff. We've got private providers. So we've got another advocate here who provides weight management services after referrals from GPs. The University of Lincoln, CCG, which doesn't exist anymore. It probably does the same thing, but it's given it a new name. And we have a GP from there who is taking part as an advocate. And we have a ULH safeguarding nurse specialist for dementia and research staff from ULH. So we're bringing people together from various health and social care organisations. I'm getting nervous because I have to hurry up and finish because I'm scared of Jazz in case he comes and tells me to finish it. So I'll go quickly. The first newsletter went out in July 2022, second newsletter in October. We've invited our advocates to the conference because we want to feel part of this. And we've got the database for contact purposes, and the national JDR team have given our advocates reviewer rights to the JDR platform. So not only can they see what studies they are eligible for, they can also see a whole range of studies. So they can talk to people about joining dementia research and show them the opportunities that are available. We've got some conversation going, which is great because it don't want all about me. I want people to talk to each other. And recently our LCHS research team responded to something I put on WhatsApp about Alzheimer's Day. And that was actually yesterday. And they said, where's the screensaver? And I went, I have no idea. And so I contacted JDR and they went, oh, we haven't got one, but we'll develop one. And in terms of bringing really good research to Lincolnshire, I was able to attend a social sciences conference at the University of Lincoln. There was a fabulous presentation by a researcher for a study for people with mild cognitive impairment. It's producing, it's got a therapy, it was in pilot, showing some really, really good results. And I approached him and I said, look, we've got all these advocates really interested. We're really interested in this. And he said, oh yeah, well, I was going to Nottingham, but I'll come to you as well. So we've started to bring in the fantastic research. So in summary, we've met quite a lot of our aims. We've only been going 4 months and it's really exciting. Things are happening. People are starting to talk to each other and we're achieving quite a lot of our aims. The challenge is going to be to keep it going because I think it's reasonably easy to set these things up. The challenge is keeping them going. So that's where the work has moved to. There's 2 things you can do today if you're interested. First of all, you can register for JDR. We've got a manned stand downstairs, or you can register online by phone, speak to our colleagues down there who will be able to just give you a paper registration form and you can do that. The other thing you might like to do is to join the Lincolnshire JDR advocates. We'll be delighted to hear from you. There is an expression of interest form on the table downstairs, or you can speak to me, and we'd be thrilled to have you as part of our team. Thank you for listening. Any comments or questions? Right, now the fun bit. So can I introduce you to Sandra and Becky?
Thank you, Anne. Round of applause for Anne.
Hello everyone, we'll do our best to give you some fun, a little bit of energy before lunchtime.
Okay. I'm Sandra Townsend, by the way, the one that they keep shouting about. This is our colleague, Rebecca Rutter. Should I say Becky? Okay. We're going to get you to stand up and sit down. It's just a bit of, you know, energy, get your feet moving, etc. So
we're going to show you some joint dementia research facts, and we'll ask you to read them and decide which answer is correct. So stand up if you think it's true, and sit down if you think it's false. So if you get it wrong, please sit down and stay sitting. And I will say we do have members of our team spotting, just to make sure, not that we were questioning anybody's truthfulness, but we have got spotters in the room. There is a prize.
you will get a prize at the end of this.
So there will be a prize for the last person standing, and the winner will take home an Echo Dot with clock and smart bulb worth £50.
Yay! Now, everybody online as well, we'd like you to stand up also. Now, anybody who can't stand up, can you put your hands up? So it's a hands up, down, instead of bums up, down.
Oh,
we'll have to pretend we can see them. A colleague downstairs is definitely watching you.
Okay, so we're now going to have a practice round. So if everybody could please stand up.
Are you all standing up online?
So technological changes have been much slower in healthcare than in sectors such as banking and retailing. So remain standing if you think that's true, or sit down if you think it's false. So everybody thinks it's true. It's true. So if you're standing, you're correct and you are still in the game. But if you're sitting, you're wrong and you would have been out of the game. But as that's just a practice, we will continue to the first question.
So everybody remain standing, and if you sat down, could you stand up? Everybody online, can you all hear us? Put a message in the chat. Okay.
So fact one, you can sign up for joint dementia research from the age of 16. So remain standing if you think it's true and sit down if you think it's false. So it's false. You have to be over 18 to sign up to JDR. So everybody sit down, and if you said true, you are to remain seated. Sorry.
Okay, everybody online got that? Okay, now if you got it wrong, obviously you'll remain seated. Everybody else stand up again.
Okay, so fact two, nearly everyone knows someone with dementia. There are 25 million people in the UK who have a family member or friend with dementia. So stay standing if you think this is true, or sit down if you think it's false. It's in fact true. 25 million people in the UK have a family member or friend with dementia. So please stay sitting if you said false, as you're out of the game.
Okay, everybody stand who's still in the game.
So fact 3, Dementia Action Week falls in April. Stand up if you think it's true, sit down if you think it's false. Okay, it's false, it's in May. So please sit down and remain sitting if you said true as you are out.
I can see you. Sit down, Leslie.
It's got eagle eyes. Fact 4, in memory of the late Dame Barbara Windsor, the government are encouraging volunteers to sign up for dementia research by joining Bab's Army. Stand up if you think it's true and sit down if you think it's false. It's true. It is called Bab's Army. So please stay sitting down if you said false as you are out.
Okay.
They're doing quite well.
Mm.
They are doing quite well.
How are you doing online?
Okay, so fact 5. How much do you know about JDR? LPFT has been involved with JDR since 2015. Stand up if you think it's true, sit down if you think it's false. It's true. LPFT has been involved with JDR since the Dementia Challenge programme started up in 2015. So please stay sitting down if you said false as you are now unfortunately out.
So how many are in online? Okay.
Fact 6, 79 JDR studies have taken place in the East Midlands. Remain standing if you think this is true, or sit down if you think it's false. We've got some conferring going on.
Decided?
Yeah. It's false. There are 72. So please sit down if you said true as you are out.
Is there anyone standing online?
Wait. Yes, I'm standing online. I've got all your answers correct. I think I deserve this dot.
Well done. Can
Yeah,
you say
I think
your
I deserve
name?
your dot.
So how many?
There's 2 people. There's 2. Okay, we'll keep going.
Okay.
So JDR opened to the public online in 2014. Remain standing if you think this is true, or sit down if it's false. It's false. It was 2015. Joint Dementia Research celebrated its 7th year this year. So please sit down if you said true as you are out. Are they still both in? Oh.
Are they up or down?
Oh, that's me. Oh.
Who's in? Okay. Another question?
Tiebreaker.
Okay, we're going to skip these next facts.
Okay, so here's the tiebreaker question. Drum roll.
No, for the next one, it's
How many volunteers do you think have registered with JDR in the UK since it started? So the closest to the answer wins. So this is your guess. How many volunteers do you think have registered with JDR in the UK since it started? So online people, if you could type your answer in the chat. And have we got
what's the other one?
So
How many?
So we've got answers from both of them. So the answer is in fact 52,915 people. So do we have a winner?
15,000.
Yeah. Yay, congratulations.
Well done. Congratulations. You are the winner of an iDot with clock and smart bulb. Well done, everybody. We'll pass you back to Jazz.
Right, what a great session. Thank you very much, team, for that. It's lunchtime now, so we're back at 1:30 for the siren studies here, and then later on we've got the breakout session. So if you just break for lunch for now and back at 1:30. Thank you.